Then it is my pleasure to introduce Dr. Kousi. She is a colleague of mine and a pediatric cardiac anesthesiologist at the Onassis Cardiac Surgical Center in Athens in Greece. And I would like to recall that she is also a co-author of the EACTAIC Pediatric Cardiac Anesthesia Fellowship Curriculum, which has been well received in the pediatric cardiac anesthesia community. So, Theofili, it's my pleasure to ask you to talk about the Fontan circulation revisited, which means what is the current perioperative management in the context of understanding this unique physiology?
So thank you very much for the nice introduction, and I would also like to thank our congenital subcommittee and the educational committee for giving me the opportunity to be part of this webinar with so many distinguished speakers. So my talk is about, as previously mentioned, the Fontan circulation and its implications on our anesthetic practice. And as we all know, the Fontan circulation is the solution given to many different and severe congenital heart defects that have only one functional ventricular cavity. The approach, as previously mentioned, to the Fontan circulation is staged. And so we begin early in the neonatal period, possibly with a shunt to provide oxygenation. Then we proceed with a glen, as nicely presented, to unload this ventricle, but still preserve a good oxygenation to the patient. And then after unloading the heart, we leave it to remodel, and as long as the PVR are low, we continue with performing the Fontan operation. The timing to perform the Fontan operation is quite a matter of debate, but usually it is performed from 18 months to 2 or 3 years of age. So historically, the first Fontan operation was performed in 1968 by Fontan and Baudet, and they published their work in thorax in 1971. This was a case series of 3 patients with tricuspid atresia, and what they actually did is they created a ventricularized right atrium, so they connected the right atrium via a valved homograph to the PA. Of course, there have been some modifications since then, and then in 1988 we have by Deleval and co-workers the introduction of the TCPC, which is the total cavopulmonary connection, which is now used by most centers. And actually most of the centers use the extracardiac conduit, which is a connection of the IVC via a graft, a conduit, to the PA, or alternatively, they can use a lateral tunnel connection. So the surgeon, with the aid of pericardium, uses an intra-atrial baffle that directs the IVC blood to the PA. So what is the Fontan circulation in principle? In the Fontan circulation, we have no subpulmonary ventricle. There is non-pulsatile pulmonary flow, and the pulmonary flow is driven by a pressure gradient from the relatively high pressure vena cava to a lower pressure left or common atrium. Professor Mark Guilling, who will have the pleasure to hear later on, nicely conceptualized the Fontan circulation. So he introduced the bottleneck concept, where we make a new portal system that is a system where one capillary bed pulls blood into another capillary bed without receiving energy from a pump. So we have the three bottlenecks, the venous return, the pulmonary vasculature, and the systemic ventricle. And the output through each bottleneck is determined by the pressure just above, the pressure below the bottleneck, and the resistance within the bottleneck. And in such a system, there is always a critical bottleneck, which is the major determinant of flow in the system. For the Fontan circulation, this critical bottleneck is bottleneck B, which is the pulmonary vascular impedance. And then again, Gewilling and co-workers in 2020 introduced the dam concept. So the pulmonary portal system actually acts as a dam in the cardiovascular system. So what we have in a dam, we have the upstream congestion, and this is the elevated venous pressures. We have the energy from the dam, which is the transpulmonary gradient that facilitates flow of blood into the pulmonary vasculature and allows oxygenation. And then we have a reduced downstream flow, which is the reduced preload of the ventricle.